Thanks so much, Lisa. It's really a pleasure to be here. As she said, my name is Heather Hampel, and I am the Associate Director of the Division of Human Genetics at The Ohio State University, where I've been a cancer genetic counselor for the past 23 and a half years. Today, I'm going to be talking to you about what you've always wanted to know about genetics and genomics in cancer prevention and early detection. And if you like to tweet, my Twitter handle is right there on the screen. I do have a few disclosures. I'm on a couple scientific advisory boards and have stock or stock options in one of the companies in which I'm on the scientific advisory board for, and a company that's working with the American College of Gastroenterology to provide genetic services. None of those will impact on my talk today. So I want to talk to you, take you first back a little bit to some basic genetics. And I actually do this with my patients in clinic. And I think it's a great way of understanding how cancer susceptibilities work. So as you know, we all have 46 chromosomes. You get 23 from your mom and 23 from your dad. So they come in pairs like you see here on the screen. Each chromosome has thousands of genes on it. There's about 20,000 genes altogether strung along these 46 chromosomes. And each gene codes for one protein or substance that your body needs to grow and develop properly. So I like to say the mix of these 20,000 genes is the recipe for you, determining things like hair color, eye color, height, and as we're starting to learn, predispositions to certain diseases. So there are genes among these 20,000, whose job it is really to protect us from getting cancer. We call them tumor suppressor genes. I like to describe them sometimes to my patients as the brakes in the car. As long as they're working, the brakes stay on, and the cells grow nice and slowly, dividing when they should and dying when they should. So all of us have these genes, and we want them to be working. So what happens in somebody with an inherited cancer susceptibility syndrome? Let's look on the right side of the screen. So here you'll see both pedigree, which is a family history as we draw them in cancer genetics, where squares are women and circles, or squares are men and circles are women. So here you'll see in this bottom generation, a young woman who has cancer. She has a brother. If you move up a generation, her father had cancer. There's her mom. Moving to the left, a paternal aunt had cancer and a paternal grandmother had cancer. So here we have what we would consider a 3-generation family history of cancer, and that is going to raise some red flags about an inherited cancer susceptibility syndrome. What happens in our inherited cancer susceptibility syndromes is that somebody is born with what we call a pathogenic variant, or they used to be called a mutation, some sort of mistake in one of those tumor suppressor genes that we talked about. And because that's inherited from their mom or their dad, it's in every cell of their body from the day they're born. Luckily, we have 2 copies of every gene. So if we have one copy that's not working, inherited from our mom or our dad in every cell of our body, we have another copy that is working just fine from our other parent. And the good news is that working copy is going to compensate for many years, and the tumor suppressor works, and we don't get cancer. So we don't typically see a lot of childhood cancers in these inherited cancer susceptibility syndromes. They're more adult onset. And the reason is that one day over the years, the odds are pretty high that just by chance, as our cells are dividing, one of our at-risk cells will acquire a mistake in the working copy. And so now you have a cell that has no more working tumor suppressor gene. The brakes come off, the cell starts to grow too fast, doesn't die when it should, and that cell becomes the cancer. So basically, people with an inherited cancer susceptibility syndrome are born one step closer to getting a cancer because of having that one copy of that tumor suppressor gene not working in every cell of their body from the day they're born. So when we do genetic testing, we can tell people whether they have this mutation or not. What we can't tell them is when the second mistake will occur. And when you look at a hereditary cancer family, you might see one person with cancer at age 36 and another who didn't get cancer until age 52. And that's just all left up to chance and when those second mistakes happen during our lifetime. We can't tell them where they'll get a cancer, but we do know the organs that are at increased risk. So depending on which gene is not working, that tells us which cancers they're at higher risk for. And so we can screen or try prevention options for those specific cancer. We also can't tell them how many times this will happen. And so a red flag for a hereditary cancer syndrome is always a person who's had more than one primary cancer. I mean, I'm not talking about recurrences or metastases. I'm talking about whole new primary cancers. So any of us could get a cancer in our lifetime. In fact, 1 in 3 of us will. But when you see someone get 2 different cancers in their lifetime, you start thinking maybe there's an underlying susceptibility there. And so that is another red flag, because the second mistake can happen 1 year, successfully treat that cancer. 6 years later, it happens again, and we have a whole new primary cancer. So this would even apply to things like bilateral breast cancer, where you have it in your right breast. 6 years later, you get it in your left breast, a whole new primary, not spread or recurrence from the first one. We also can't tell people for sure that they will even get a cancer if they're born with one of these mutations. The risk is higher, but it's not 100%. So some people just don't get that second mistake and never get a cancer. And I have found 100-year-old people who have the mutation that's running in their family and just have never gotten cancer. And certainly we're interested, in studying, was there anything they did or didn't do in their life that might have helped keep them from getting cancer, but it may have just been chance. So you'll see under the family tree here that the red flags that we're going to look for hereditary cancer syndrome, which we've kind of talked about, is this earlier age of diagnosis. Because you're one step closer, it doesn't take as long on average. So earlier ages of diagnosis is a red flag that the cancer might be hereditary. The multiple generations with cancer. That's more concerning than a couple siblings with cancer, because we call it a vertical transmission pattern, where you can see it getting passed down through the generations. Bilateral or multiple primary cancers we've talked about, and then clustering of certain cancers that we know go together. I think people are well aware that breast and ovarian cancer run together in families. I don't think people necessarily know that prostate and pancreatic cancer are also seen in our breast ovarian cancer families. And people are much less aware of Lynch syndrome, which we're going to talk about today, which causes an increased risk for colon, uterine, ovarian, and stomach cancers. And I just want to spend 1 second talking about sporadic cancers. So most cancers are not hereditary. We think about, depends on the cancer, but somewhere between 10 and 15% of most cancers are hereditary, with some notable exceptions like ovarian, where it's a much higher percent. So the rest of the cancers are sporadic or familial, which we aren't going to talk about today. But sporadic just means they popped up by chance alone. So you don't tend to see any family history, and these individuals are born with all of these tumor suppressor genes working just fine. Now, as they age, they can acquire these mutations. Maybe the cell dies, nothing comes of it, but if it lives long enough and gets enough of them, it can stop working and we can see a cancer develop. These mutations occurred in the person's body during their lifetime. They were not born with them, and they cannot pass them on to their children. These are the mutations that they look for when someone gets tumor sequencing done on their tumor at the time of diagnosis now, which is in a growing area of interest, because sometimes our oncologists like to know what are the mutations that are driving that cancer, because sometimes it gives them an idea of what therapies to choose. You'll note that the cancers tend to be diagnosed at later ages with little or no family history, and single or unilateral tumors in the sporadic cases. Hereditary cancer syndromes follow an autosomal dominant inheritance pattern for the most part. There are a few exceptions. So if somebody has one of these mutations, like this person on the top left, there is a 50% chance that they'll pass the mutation on to their children. So in this case, that's the capital A. And there is a 50% chance they'll pass their working copy on to their children. Assuming they've married or had children with someone who does not have that mutation, that boils down to a 50% chance for each child that they'll inherit the cancer susceptibility syndrome and have the increased risk for cancer. And if they inherit the mutation, then their children move to the 50% risk. But it's equally likely that they pass on their working copy, then the individual has no increased risk for cancer and cannot pass it on. So it essentially stops there in that branch of the family. So this is very powerful. If we can find a mutation in a family that's causing cancer, we can let the at-risk children, brothers, sisters, aunts, uncles, cousins know if they inherited it or not. And if so, we can implement increased screening and prevention. And if not, that's really great news because they can essentially follow the American Cancer Society guidelines for screening in the general population. So we've kind of hit these already, but when to suspect a hereditary cancer syndrome. So I feel like I get to play detective in my work, and now I'd like to, deputize all of you to do the same. As you think about your own family histories or your friends and family's family histories, do they have these characteristics that make it more likely to be hereditary? And if so, they should probably see cancer genetics. So again, cancer in 2 or more close relatives on the same side of the family. I get a lot of calls from people who say both my mom and dad had cancer. There's 100% chance I'm going to get cancer. It doesn't work that way. It's actually more concerning if there's several cases on the same side of the family because your mom and dad are not genetically related to each other. Earlier ages of diagnosis, we've mentioned. Multiple primary tumors. That goes with also bilateral tumors. Rare tumors like male breast cancer and some others that are rare can be more likely to be hereditary. And then these combinations like breast, ovarian, prostate, pancreas, or colon, uterine, stomach, ovarian. And then the vertical transmission pattern that we talked about where multiple generations are affected. The most common hereditary cancer syndromes we're going to talk about today. So hereditary breast ovarian cancer syndrome, which is caused by mutations or pathogenic variants in the BRCA1 or BRCA2 genes. We're going to talk about Lynch syndrome, which is due to mutations in one of 5 genes called the mismatch repair genes, MLH1, MSH2, MSH6, PMS2, and EpCAM. That's the one that causes colon, uterine, ovarian, and stomach cancers. And those 2 conditions are considered tier 1 diseases by the CDC. Their third condition that's considered a tier 1 disease is not a cancer syndrome. It's a high cholesterol syndrome that runs in families called familial hypercholesterolemia. These 3 conditions are considered tier 1 because they are common enough in the general population, easy to test for, and they're actionable. There's something we can do about them that makes the person less likely to have a bad outcome. One recent study at the Geisinger in Pennsylvania assessed for these 3 conditions in 50,000 healthy people in their health plan and found that 1.32% or 1 out of 76 individuals had one of these conditions. That's extraordinarily common. Compare that to the 1 in 800 positive rate for newborn screening, which every newborn in America gets a heel stick and gets tested for a number of genetic conditions that are much less common than these 3. And so I think this is a real public health concern. We have estimates that probably 90 to 95% of individuals with hereditary breast ovarian cancer syndrome and Lynch syndrome are not aware of their diagnosis. So we're really trying to work hard to close that gap and get these individuals identified so that they can benefit from screening and prevention. So I mentioned about 10% or 15% of most cancers are hereditary. That is true of breast cancer. There's an additional 15% that are considered familial, where there might be some minor genes plus shared environment, making the family slightly more likely to get breast cancer, but 75% then being sporadic. Ovarian cancer, a full quarter, almost 25% are hereditary, and 76% are sporadic, and there's not really this familial component. The BRCA1 and 2 genes are on chromosomes 17 and 13, and everybody has them, and you want them to be working. If you have a non-working BRCA1 or BRCA2 gene, you have significantly elevated risk for the cancers I've mentioned. And here you can see the general public has this about 13% lifetime risk for breast cancer, and that's around 70% for people with BRCA1 or 2 mutations, so significantly elevated. The ovarian cancer risk is higher with BRCA1, 39 to 58%, compared to BRCA2, where it's 13 to 29%, and the general population, where it's a rare cancer at 1.3%. The prostate cancer risk is significantly elevated, particularly with BRCA2. It's common in the general population as at 12.5%, but could be as high as 27 to 60% with BRCA2 and up to 29% with BRCA1. Pancreatic cancer risk is also elevated, the general public only having a 1.7% chance of getting pancreatic cancer in their lifetime, and again, higher with BRCA2 up to 10%, but elevated also with BRCA1. So when we know someone has one of these mutations, these are the cancers we're going to focus on for early detection and prevention. I do mention briefly that these mutations, there are 3 particular mutations in the BRCA1 and BRCA2 genes, which you see spelled out here, that are more common in Jewish individuals. So sometimes when somebody asks your family history, they might ask about your ancestry and your religious background. And that's because there are certain founder mutations that are more common in certain populations. For example, in Iceland, Denmark, and Finland, the BRCA2 999del5 mutation is extremely common and accounts for almost all of the hereditary breast ovarian cancer there. It means that BRCA1 and 2 mutations are more common in Jewish individuals, about 1 in 40, compared to the general population where it's 1 in 400, so a 10-fold increase. So it doesn't take as much family history for a Jewish family to be referred to genetics as it does for a non-Jewish family. But this has gotten misinterpreted, and we've done some studies in Ohio where we found that people think that non-Jewish individuals can't have hereditary breast ovarian cancer. That is not at all the case. It's very common. It's just more common in Jewish individuals. So I like to make sure that people understand that difference. What is the management if somebody has hereditary breast ovarian cancer syndrome? So for breast cancer, we're going to start breast awareness at age 18. They're going to perform their clinical breast exams every 6 to 12 months, starting at age 25. And at age 25, we're actually going to start imaging with annual breast MRI screening with contrast. The reason we don't start the mammogram yet is the risk of the radiation on a young developing breast. And then at 30, we kick in the mammograms. And so now they're getting a mammogram and an MRI annually. And a lot of people like to spread those out every 6 months because what one might miss, the other might catch. And then you have a chance to pick up any interval cancers instead of doing them both at the same time. After age 75, management's individualized depending on the person's overall health. The other discussion about breast cancer is the consideration of a risk-reducing mastectomy. At a 70% lifetime risk, some people would instead decide to do risk-reducing mastectomy to lower their risk of breast cancer as much as possible. And it has been shown to reduce the risk by about 90%. And the only reason it's not 100% is they can never remove every breast cell. There's still some under the skin and on the chest wall that can't be removed. But significantly decreased risk, lower than the general population. But of course, then there's discussions about what types of reconstruction options there are, and those can sometimes be more complicated, the reconstruction options for people than the mastectomy. And there are some risk reduction agents like chemoprevention with tamoxifen. They have not been popular in women with BRCA1 and 2 gene mutations, but they are effective. They can reduce the risk of breast cancer. So what's the ovarian cancer management? As you all probably know, there is no effective screening for ovarian cancer. So in this case, we opt for prevention through risk-reducing bilateral salpingo-oophorectomy. So that's removing both ovaries and both fallopian tubes between the age of 35 or 40, or after childbearing is complete. Because ovarian cancer in women with BRCA2 mutations occurs a little later than with BRCA1, women with BRCA2 mutations can kind of wait till 40 to 45. There is some evidence of a slight increased risk for a serous uterine cancer among BRCA mutation carriers. So some people will consider a hysterectomy at the same time as their ovaries and fallopian tubes are removed. If someone's delaying that surgery, we recommend that they try a transvaginal ultrasound with color Doppler, starting at age 30 to 35, and a CA-125 blood test to attempt to screen for ovarian cancer. But again, no evidence that that's very effective. Oral contraceptives actually have been shown to reduce the risk of ovarian cancer, and the low doses used today do not increase breast cancer risk significantly. So oral contraceptives are not counterindicated and may decrease the risk for ovarian cancer. For men, breast self-examination and training beginning at age 35, clinical breast exams annually beginning at age 35. With BRCA2, we actually recommend prostate cancer screening, including annual digital rectal exam and PSA tests beginning at age 40. And for BRCA1, consider prostate cancer screening at age 40. Screening for other cancers in both men and women. There's no specific guidelines for melanoma, but it has been seen at a slight increased risk, particularly with BRCA2. So, sun avoidance and annual full body skin exam are not a bad idea and are not invasive. The pancreatic cancer screening, it is recommended for people who have a BRCA1 or 2 mutation if they have a relative with pancreatic cancer. And so we start that at 50 or 10 years younger than the earliest diagnosis, and they either do endoscopic ultrasound or an MRI to look for any kind of cysts that are concerning in the pancreas. All other screening is American Cancer Society guidelines. And I haven't left myself much time for my favorite syndrome that I work with on research, but Lynch syndrome, as we mentioned, is due to mutations in the mismatch repair genes. These are the 4 main ones, and EpCAM can cause Lynch syndrome, but basically because it shuts down MSH2. Lynch syndrome is common. 1 in 279 individuals have it. It causes colon, uterine, stomach, and ovarian cancer, among others. Those cancers are preventable with earlier and more frequent screening. And again, 90 to 95% of individuals are not aware of their diagnosis. Someone who has Lynch syndrome has elevated risk of colon cancer, and the risks vary depending on which gene is causing it. So you can see as low as 9 to 20% in someone with a PMS2 mutation, and as high as 61% in someone with a pathogenic variant in MLH1 or MSH2. And that compares to the general population risk of 4.2%. Endometrial cancer, 3.1% in the general population, up to 50% in some of the higher risk genes. Stomach cancer, kind of seeing less of that in the US, even among individuals with the higher risk gene mutations, but still elevated. And ovarian cancer risk can be as high as 38% with MLH1 and MSH2. 13% with MSH6. And so I think historically people have thought of BRCA1 and 2 for individuals with ovarian cancer, but they might indeed actually have Lynch syndrome. So what's the screening for Lynch syndrome? For MLH1 and MSH2, they start colonoscopies at age 20 to 25 and repeat it every 1 to 2 years. With MSH6 and PMS2 having the slightly lower risk at later ages, they start at 30 to 35, but again, repeat it every 1 to 2 years. So these individuals are going to get a lot of colonoscopies in their life. But we know if we remove those precancerous polyps, we have a really good chance of preventing colon cancer from occurring even in the first place. For endometrial cancer, really the key is knowing the symptoms. Any bleeding between cycles or after menopause, get right into the gynecologist. Some people do consider a hysterectomy after childbearing, and some people do consider endometrial screening with endometrial biopsies every 1 to 2 years starting in their 30s. There is no evidence that the screening changes outcomes, though, because endometrial cancers tend to get diagnosed early and people do well. Ovarian cancer, same issues as with BRCA1 and 2. So some people do consider removing their ovaries and fallopian tubes after childbearing. For stomach cancers and small bowel cancers, we really kind of only screen if there's a family history. Urinary tract cancers, which can also be seen with Lynch syndrome, we pretty much focus on people who have a positive family history, or particularly men with MSH2 mutations who are known to be at higher risk, and they can do urinalysis annually starting in their 30s. Pancreatic cancer, same screening as with hereditary breast ovarian cancer syndrome, only for people who have a mutation and a family member with pancreatic cancer. It's controversial whether there's any elevated risk for breast or prostate cancer with Lynch syndrome, but even if there is, it's not elevated enough to warrant increased screening. So general population screening. Some evidence of glioblastoma, increased risk with Lynch syndrome, so just an annual physical and neurological exam. Aspirin has been shown to decrease the risk of colon cancer for individuals with Lynch syndrome. So we do recommend that our patients with Lynch syndrome take an aspirin a day for at least 2 years. They're not quite sure of the optimal dose and duration. At this point, a lot of people are recommending a baby aspirin or 1 adult tablet, but there is a study ongoing in Europe that will identify the optimal dose and duration of this treatment. It's very exciting though, because it definitely looks like it decreases the risk by at least 65% for individuals with Lynch syndrome. And lastly, I always like for everyone to know that the only risk of doing genetic testing at this point is this concern about insurance discrimination. So there is a federal law in place called the Genetic Information Non-Discrimination Act, or GINA, and that prevents health insurers or employers from discriminating against someone based on genetic test results or family history. So the only loopholes then are life insurance, disability insurance, and long-term care insurance. So this is something that we always discuss with our patients prior to testing. And some people make sure they have those types of policies in place before they do their testing, because it's less likely to lose a policy that you have than to get rated higher or get denied. But this has been, the GINA law has really given a lot of reassurance to patients who need their health insurance more than anyone else because they need to do this high-risk screening and prevention. So take-home messages are that all cancer is genetic due to genes that are not working properly and are causing those cells to grow out of control and not die when they should. But not all cancer is hereditary due to a mutation that was inherited from a mom or a dad and can be passed on to their children. When you're risk assessing, I'm more concerned about ages of diagnosis than the total number of cases. Ancestry can help change our risk assessment. More rare tumors make a bigger impact on risk. And genetic counseling and testing and identifying these high-risk families allows for the proper cancer screening so that we can keep these individuals from getting cancer in the first place. Thank you so much.